Good evening, everyone. Hi, Sally. Welcome, everyone, to the 11th installment, believe it or not, of Northminster Presents, brought to you by the Men's Prayer and Study Group, a group of fellows who get together every Wednesday night, or morning actually, and make attempts at studying the Bible. And some short time ago, we decided to try and launch something on this nature, and we're very happy to be here. I've been extremely excited about tonight's topic. It's of ultimate importance to us, I think. Tonight's topic is about infant and maternal mortality in our own home state and in our own home of Indianapolis. The truth is that our very neighborhood is one of the worst in any nation in the world of developed nations. That's an extremely sad commentary to think that in our own backyard we are working with these kind of conditions. So we are fortunate tonight to have one of our very own who works daily to help remedy the situation in our local community, Lauren Lancaster. And yes, she is Roz and Wes's daughter. And one of my major questions tonight is going to be, what's it like being Roz's daughter? You know? I think that'd be a good question to ask. But beyond that, Lauren has her bachelor's and master's degree in public health policy. She has worked with the Indiana Family and Social Services Administration as well as IUPUI to affect legislation in the state of Indiana on these critical issues. Currently, Lauren is a statewide health manager for the Indiana Minority Health Coalition. Please welcome her as she shares disturbing information on these issues and what we might be able to do about it. We will take questions after her presentation. We'll have people going around with hand mics that can deliver to you. So be prepared for that and plan your responses at the end. Please welcome Miss Lauren Lancaster.
Good evening, everyone. Can you guys hear me? All right. As Jerry mentioned, my name is Lauren Lancaster. I serve as the Maternal Child Health Manager at the Indiana Minority Health Coalition. And thank you guys for attending my presentation tonight on the state of maternal infant health. So on our agenda tonight, I'll go through a brief history related to maternal health, followed by maternal mortality and infant mortality at a national and state level. Then we'll move on to legislation, some maternal child health initiatives, advocacy. So if you guys are interested in helping, I'll have some tips for you guys to become involved. And then we'll end with some personal stories. Yes. Okay. Can you guys hear me better? Great. All right, so a little bit about the Indiana Minority Health Coalition. We are a statewide nonprofit that was created to help eliminate health disparities among minority populations through advocacy, policy, and research. We have 22 coalitions and affiliates across the state of Indiana, and we were founded in 1994. So tonight I would be remiss if I did not discuss the story of Betsy, Lucy, and Anarcha. So Betsy, Lucy, and Anarcha were slaves that were located in Montgomery County, Alabama, and they were all mothers. And through childbirth, they ended up developing a condition where they were not able to control their bladders. So as a result, they were not able to do any hard labor, and so, of course, their slave owners did not like that. And so their slave owners came into contact with a doctor named Dr. J. Marion Sims, who said that he was in the process of creating a procedure that could help fix their issues. So their slave owners sent them to live with Dr. J. Marion Sims. And over the course of 5 years, these women had faced procedures where they were not provided with anesthesia, they were restrained, and then they were left naked on the bed. And it wasn't until Anarcha's 30th procedure that this procedure was successful. And so because it was successful, Dr. J. Marion Sims presented on his findings. And in his findings, he did not mention that he operated on slaves. He said that he operated on white women who he provided anesthesia to and were covered, which was incorrect information. Because of the procedure that he created, he was named and called the father of modern day gynecology. So as a result, there were statues created in honor of him, and it wasn't until a couple of years ago that the stories of Lucy, Betsy, and Anarcha became polarized, and statues of Dr. J. Marion Sims were taken down. So as I go through my presentation tonight, just keep in the back of your mind these three women and what they went through. So I'm going to, again, talk a little bit about maternal mortality at a national and a state level. And I want this to be an interactive presentation. So I'm going to have a couple of questions for you, multiple choice answers to help you guys out. So as I go through the answers, if you think 115 is correct, I'm just going to ask that you raise your hand. So the first question is, how many women do you think died in the U.S. of maternal mortality in 2021? Maternal mortality is defined as the death of a woman during pregnancy or 1 year postpartum. So if you think 115 women died in 2021, go ahead and raise your hand, and so on and so forth. So again, I'll ask the question, how many women do you think died in the U.S. of maternal mortality in 2021? If you think 115 women, raise your hand. Don't feel embarrassed. This is all a learning opportunity for everybody. Nobody? Okay, if you think 425. 739? Okay, 1,205. If you said 1,205, you are correct. So again, maternal mortality is defined as the death of a woman during pregnancy and 1 year postpartum. The current maternal mortality rate for the United States is 32.9 deaths per 100,000 live births. So what that's saying is for every 100,000 babies that are born alive, on average, 32.9 women die. And so you might say, Lauren, that's not bad. But when you look at other comparable countries such as Japan, Spain, and Australia, they have about 3 to 5 deaths per 100,000 live births. So the United States is the worst ranked developed country regarding maternal mortality. Common causes of death include mental health, hemorrhaging, substance use disorders, cardiac conditions such as preeclampsia. Black women die of preeclampsia and other cardiac conditions. White women tend to die of mental health and substance use disorders. So when you look at maternal mortality in terms of race and ethnicity, what you will find is from 2018 through 2021, there was an increase across all races and ethnicities. However, I don't have a little pointer with me tonight, but the Black population has a maternal mortality rate of 69.9 compared to white women who are at 26.6, and then Hispanic women are at 28. So Black women die at extremely higher rates than white and Hispanic women. And that is attributed to a lot of things. So one is racism and discrimination, as well as some social determinants of health, which I'll kind of get through a little later on. But myself, as a Black woman with my master's degree, I have the same likelihood of dying as a white woman with her high school diploma. So when you look at the reasons or the percentage breakdown of maternal deaths, what you will find is about 31% happen during pregnancy, 17% happen during the time of labor and delivery, and then 52% happen postpartum. And when you look at that 52% number, what you'll find is about 21% happen between the first and the 6th week postpartum. So next is access to prenatal care. So 91.7% of white mothers, 85.2% of Hispanic mothers, and 84.1% of Black mothers all receive prenatal care, early prenatal care, during that 4-month of finding out that they're pregnant. So Hispanic and Black women are a little bit less than white mothers as it relates to early prenatal care and access. So just a little bit ago, I mentioned the social determinants of health. And in public health, if anybody knows about public health, social determinants of health is our framework, so kind of what we base public health on. And so those categories include economic stability, neighborhood and physical environment, education, food, so do you live in a food insecure area, community safety and social context, and then healthcare systems. And all of these fields have something to do with mortality, morbidity, the health of a country across the board for any spectrum. So I'll give you an example of neighborhood and physical environment. So if I compare a woman that lives in Carmel to somebody that lives on the Near East Side of Indianapolis as it relates to neighborhood and physical environment, the woman that lives in Carmel most likely has a vehicle. She has access to parks that are nearby or walking trails. Her area is probably she can easily walk through the area with sidewalks and whatnot. And then zip code and geography, she might live near a lot of restaurants or areas of affluence. However, a woman that lives on the Near East Side, she might not have reliable access to cars, so she might have to walk or use the bus. There might not be a lot of parks in her area. There might not be a sidewalk for her to safely walk up and down the street. So both of these women are pregnant. The woman on the Near East Side works maybe a lower income job, and she's not able to have PTO to take off to go to her prenatal appointments. So she has an appointment at 3. She doesn't get off from work until 2:55. She doesn't have a car, so she has to catch the bus. So she either has 2 options. She knows she's late for work, so she can either catch the bus, miss her window for her appointment and be turned away, or she can just say, hey, it's been a rough day. I've got other things on my list. I just won't go today. And that might continually happen over time, and so she's missing all of these doctor's appointments. Whereas the woman that lives in Carmel, she might have a car. She can have some PTO time to take off from work to be able to get to that appointment on time and go see her providers. So my next question is, where do you think Indiana ranks for maternal mortality? Now, these answers are going from worst to best. So if you think Indiana ranks 3rd highest, you'd raise your hand, 15th, in the middle at 35th, or pretty good at 40th. So where do you think Indiana ranks for maternal mortality? If you think we're 3rd worst in the country, raise your hand. 15th? 35th? You think we're doing okay? Middle back. 40th. Okay. If you said 3rd, you are correct. So my manager likes to say that Indiana is at the top of the bad list and the bottom of the good list. So we currently rank 3rd in the country for maternal mortality. Black women are 2 to 3 times more likely to die compared to white women in this state. There is an organization that's called the Maternal Mortality Review Committee, and they go and they review all the deaths, maternal deaths, case by case. And they project that about 79% of maternal deaths are preventable here in the state. And then the state, a third of the counties live in an OB desert in the state. So they either don't have access to an OB, they have a hospital, but that hospital doesn't have a labor and delivery unit, or they don't have a hospital at all. So next, we're going to be talking about infant mortality. And infant mortality is such a vital topic because infant mortality, countries are judged on that because that looks at the health of a country overall. So nationally, of course, Indiana is not ranked great. Infant mortality is the death of an infant before his or her first birthday. The U.S. has the highest infant mortality of any high-income country. Current infant mortality rate is 5.6 deaths per 1,000 live births. So for every 1,000 live births, on average, about 5.6 babies die. Black infants are 2.4 times more likely to die compared to white infants. And causes can include low birth weight, congenital anomalies, SUIDs, which is sudden unexpected infant death syndrome. So that encompasses safe sleep, or if you put your baby down to sleep and they just don't wake up. And then accidents, and then maternal complications. So, another question here. How many babies die a year due to infant mortality in Indiana? If you think 101, raise your hand. I think you guys are catching on to me. If you think 379, raise your hand. 536, 748. Okay. Answer is 536. I tried to help you guys out there a little bit. Didn't go with the highest number. So when you look at Indiana for infant mortality, we have an infant mortality rate of about 6.7 deaths per 1,000 live births. So if you remember, the national average is 5.6. We're 6.7, so a little bit higher. Again, 536 babies die a year. That's about 45 babies a month that die. Indiana is ranked 8th highest for infant mortality. So the graphic over here to the right of me is a comparison between 2020 and 2021. The infant mortality for Hispanic babies rose from 6 to 8.2. It went down just a smidge for white infants from 5.5 to 5.4. For black infants, it remained the same, but black infants died at a rate of 13.2, so almost double here in the state. So luckily, the State Department of Health is able to track infant mortality at a county level data. So between the years of 2017 through 2021, we're able to know that black infants had the highest rates of dying in Elkhart County at 22.7, Vanderburgh at 19.1, Tippecanoe at 16.5, Allen County at 15.5, St. Joe County at 15.2, Lake at 13.7, and then Marion rounds out at 11.1. And then for white infants, highest counties were Adams at 10.3, Shelby at 9.2, Grant at 8.0, Delaware at 7.7, Noble County at 7.6, Vigo at 7.4, and Wayne at 7.4. And then for Hispanic babies, infant mortality was highest in Elkhart County at 8.3, Allen at 8.1, Lake at 7.9, and Marion at 6.1. So if you catch my drift here, we started out at 5.6 for nationally, 6.7 for the state of Indiana. Elkhart County for black infants is at 22.7. For white infants, Adams is at 10.3, and Hispanic babies in Elkhart, it's 8.3. So numbers just continue to go up. The state is able to offer us zip code level data down to the highest zip codes across the state of Indiana. So for Marion County, highest zip codes are 46218, 46241, 46219, 46222, 46201, 46224, and 46235. And the zip codes in red were the highest, or the zip codes in red were the ones that just added. So if you look at Marion County 46218, I can read it off because I know it's small print. So between 2017 and 2021, there were 2,481 births during those years. Of those births, 30 babies died, giving that zip code an infant mortality rate of 12.1, which is almost it's double the state rate. So we are also able to see by race and ethnicity why these babies are dying. So overall in the state of Indiana, reason number one is perinatal risk, that's low birth weight or preterm birth. Next would be congenital anomalies, then SUIDs, assaults and injuries, and then other. But if you look at the non-Hispanic black, what you'll see is a flip. So perinatal risk is still one. A lot of black babies die due to low birth rate or being preterm. Next, though, is SUIDs, and then congenital anomalies. So oftentimes I hear on social media or amongst talks like, oh, I'm on my second baby, or my mom co-slept with me, and, I'm here. But all it takes is that one time. I've heard stories of mom leaving baby with a babysitter. Babysitter wants to let the baby sleep, and so they have blankets and pillows so the baby doesn't fall off. Babysitter leaves the room. What happens? Baby rolls over, and baby is not able to then roll themselves back over, so they suffocate to death. Or you're co-sleeping with your baby because you're tired. Oh, I just want to have my baby close to me, and you roll over on the baby, and you don't hear the baby, maybe like a subtle movement, or you don't hear the baby trying to gasp for air, and you essentially kill your baby. And so these are all devastating experiences. I know that the State Department of Health is working diligently on trying to promote and educate safe sleep, as well as offer baby boxes if individuals do not have cribs and whatnot, and then meeting people where they're at. It's one thing to go into a neighborhood and say, you're doing everything wrong, this is what you need to do right. Those people are not going to want to learn from you. So meeting the people where they're at is definitely what they're trying to do to overcome this issue. So next we're going to talk about legislation and what's been going on the federal and the state level. So on a federal level, the Black Maternal Health Caucus created 13 bills called the Momnibus. And these bills are being voted on individually. Some have passed and some haven't. So I'll just go through briefly 2 bills tonight. The first bill is the Social Determinants for Moms Act, written by Representative Lucy McBeth. This bill extends WIC eligibility periods so new moms and babies can access the nutrition support they need. It expands access to safe, stable, adequate housing for pregnant and postpartum people and their families, and then provides funding to local health departments to address social determinants of health, like access to transportation and childcare. So that social determinants of health graphic that I showed earlier, this is what they're trying to do to expand that. Next, we have the Kira Johnson Act, and you'll hear Kira's story a little bit later on. This was written by Representative Alma Adams. It awards funding to community-based organizations working to promote Black maternal health equity, provides funding to implement trainings on bias and racism for all employees in maternity care settings, and then establishes respectful maternity care compliance programs to promote accountability in hospitals and birthing settings. Next, we have the Indiana legislation. Here in the state of Indiana, we're still working. The groups on the ground it's uphill battle, but we're working on it here. So in 2022, we had House Bill number 1140, authored by Representative Ann Vermillion. So this extended postpartum Medicaid coverage for pregnant women to 12 months from the current status of 60 days. It removed the Medicaid limitation for pregnant women of medical assistance coverage only for pregnancy-related services. So Medicaid funds and insures about half of all labors and deliveries across the country. They're the biggest insurer. So prior to this bill being voted on and passed, women could be kicked off of Medicaid 60 days postpartum. So this bill just extended it to 12 months to give women better access to care. Next, we have House Bill number 1294, authored by Representative Dr. Rita Fleming. So our CEO at IMHC, Carl Ellison, came to find out that pregnant incarcerated women could still be shackled during labor and delivery. It was still legal here in the state of Indiana. We were the last of about 8 states to still keep that legal. Now, did it mean that that was happening? We don't know, but it was still legal for that to happen. So he talked to Representative Vanessa Summers, who works at IMHC, and she worked alongside Dr. Rita Fleming and other representatives to pass this bill, which prevents the use of unnecessary restraints on pregnant inmates who are in labor, delivering a baby, during the immediate post-delivery period, and during a medical emergency. So as you can think, if you're giving birth and you're shackled, that causes more harm and stress on baby and mom. And then if mom is being transported to another facility or to a doctor's appointment and she's shackled, she might increase her fall rate doing that. So that's now illegal to do. So some maternal child health initiatives that I think should happen and that are currently happening, and ones I hope to come. First one is increasing access to doulas. So a doula is a non-medical support person. They are there for the pregnant person while she's pregnant and then even postpartum. So they help her with advocating for herself, with breathing techniques, stretching, and help her coach her through, I should say, labor and delivery. And I'll touch on doulas a little bit later. Also increasing access to midwives and diversifying birthing locations. So during slavery times, midwives were very popular. There was a plethora of black midwives. However, they were kicked out of the profession. So I think about less than 9% of midwives are black currently today. And then as it pertains to diversifying birthing locations. So as we all know, you can give birth in multiple locations. You can give birth at home, in the hospital, and then birthing centers. So birthing centers are overseen by midwives. Countries that midwives are their primary birthing profession, they have lower rates of maternal and infant mortality. And then birthing centers are recommended for women with low birth risk. Next would be cultural training for providers. So really understanding and knowing who your patients are. I came across a story on social media. There was a labor and delivery nurse who was a black woman, and she was telling the story of one of the patients. So mom just gave birth. Her labor and delivery nurse, who's non-black, walks into the room. Mom is patting her head. So as a black woman, when I say I'm patting my head, I might have braids, I might have a wig on, I might have a weave on, right? Her labor and delivery nurse, who was non-black, thought that she was causing harm to herself and wanted to involve DCS in the psychiatric department. And so luckily there was a black nurse that said, wait. She's not causing harm. Her scalp itches, and she's just trying to scratch it, right? So luckily there was that black woman that was there that was able to stop that. If not, what would have happened? DCS might have come. They might have decided they wanted to take the child away, causing stress and harm to the mom and baby. Next is universal paid parental leave. That's just it. Universal paid and parental leave. Next is social determinants of health. I've discussed that, expanding that. And then investing in telehealth. So if mom is not able to get to an appointment, she can call her doctor and they can talk, or she can do like a video call. That way that relationship is still being able to be established and she's still getting the care that she needs. So a little bit about IMHC. So we have a community doula program. Our program is called the Community Doula Services Program. It's housed in the counties of St. Joe, Elkhart, LaPorte, Cass, Howard, and Miami counties. So if you remember back when I was talking about the zip codes, some of those counties on there were located in St. Joe and Elkhart. And then when I talked about the race and ethnicity broken down, a lot of those counties included Elkhart and St. Joe. So the program focuses on minority women between the ages of 15 to 35 who are either on Medicaid or would be eligible for Medicaid, but we don't turn anybody away. So the women stay in our program up until baby turns 1. They're able to get navigation assistance, referrals, and et cetera. Our doulas do a lot of great work. You hear stories about what their what their clients go through. So one of our doulas, she's Haitian Creole, sees a Haitian Creole population. Her client needed a C-section. So they're administering the epidural. They're asking the client, do you still feel below the waist? Because she's not supposed to. She says yes. They try another remedy. Do you still feel below the waist? She says yes. They then proceed to take her back into the operation room and cut on her, as she can still feel that pain. And so she's screaming for dear life. Luckily, our doula was in the room and told them to stop and to give her some anesthesia, and that's what they did. So you hear those stories and you think about women who don't have a doula who go through that, and there's nobody there to advocate for them. So some of the benefits of having a doula include clients are 10% less likely to use pain medication. They're 28% less likely to have a C-section, 31% less likely to use Pitocin, which starts pregnancy or labor and delivery, 34% fewer negative birth experiences, and then clients are more likely to breastfeed if they have a doula. So advocacy and what you can do if you're interested. So contacting your legislator. Oftentimes we hear that legislators don't hear from their constituents enough. If they get 2 to 3 letters on the same topic, it's a big to-do. So contacting the legislator, letting them know that you are aware of these discrepancies and where the state and where the country lies regarding maternal and infant health, and that you would like them to support legislation. Next is raising awareness of this issue to your inner circle. So if there's some nuggets that I've dropped tonight that you remember, sharing that with the people that you're closest to. Next would be volunteering or attending organization events that are in the maternal child health space. So John can attest, when he approached me, he said, give me some information. I sent John like 10 to 15 links. Like, he was ready to go to write a thesis paper on maternal child health. So if there are any events that you would like to attend, definitely reach out to me, or I can connect you with people that you need to be connected with. So tonight, I wanted to end on their stories. Tonight, you've heard me talk a lot about numbers and statistics this and statistics that, and sometimes it can be difficult to really put into frame of mind what is going on and to attach a face to a number. So I'm gonna play a few videos. These videos always make me emotional and get me in my feelings, so I might be over there crying, but just ignore me. So the first story we're gonna have is Kira's story. So if you remember, Kira Johnson was the act that the federal government was trying to pass.
Judgment for the plaintiff as so ordered.
Judge Glenda Hatchett is used to hearing cases on her television show. Now she's involved in her own heartbreaking legal fight over the death of her daughter-in-law.
My precious daughter walks into the hospital, and she never walks out.
Everybody's here to celebrate.
Kira Johnson had just given birth to a healthy baby boy. Judge Hatchett's son, Charles, is heard beaming. But a few hours later, Kira was dead.
I was irate. I was in disbelief.
Never, ever, ever did I think that I would not see her again.
Charles thought of his 39-year-old wife as a superwoman. She spoke 5 languages, raced cars, and was an avid skydiver.
Honest to goodness, she was the most amazing person I ever met in my life.
The two were excited to soon welcome a second son into their family. Kira came here to Cedars-Sinai Medical Center in Los Angeles for what should have been a routine procedure, a C-section. According to this lawsuit, when Kira was recovering in her hospital room, her blood pressure plummeted, her heart began racing, and she complained of pain in her abdomen. Her family says she wasn't taken back into surgery for 10 hours.
There were some very, very clear signs very early on that she was hemorrhaging internally.
Are you shocked that it took so long
Yes.
to get your wife back into surgery?
I was definitely shocked. We definitely pleaded repeatedly for them to take action.
His lawsuit claims doctors knew Kira had excessive bleeding and ordered CT scans, but records do not reflect these scans were ever performed. 10 hours after her C-section, she was finally taken into surgery. Doctors reportedly found 3 liters of blood in her abdomen. They were not able to save her.
The last thing she said to me was that, I'm scared. And I held her hand and I kissed her and I told her that everything was going to be okay.
His youngest son, Langston, just celebrated his first birthday without his mother. His other son, now 2.5, still wakes up crying for his mom.
And I would respond, I'll say, well, Charles, she's in heaven. And his response to me will be, well, I want to go too. Having that conversation with the 2-year-old is something that I don't know quite how I'll ever be able to figure out.
Judge Hatchett hopes by sharing their personal tragedy, they can prevent this nightmare from happening to anyone else.
We are devastated by her death, her senseless, tragic death.
Cedars-Sinai Hospital sent us a statement saying they are saddened by the death and the toll that it's taking on the family, adding they strongly support their goal of determining exactly why this happened.
So litigation right now for Kira's death is currently at the federal level, which oftentimes it doesn't even get to that level. So it'll be interesting to see updates that happen with her story. So next we have Dr. Shanice Wallace and her story. At the time of her death, Dr. Shanice was a resident at Riley.
We fulfill our purpose when we help others. That is the part that gives me peace, is that I know that Shanice was here for other people. She executed love like nobody that I know. It was her destiny to be a good doctor to every single patient.
She swept me off my feet. And I was like, I want to marry that girl. Pregnancy, for most of it, You know, it was very smooth, very exciting, up until 2 months before she's due. It was October 19th, and we were just out enjoying ourselves. And she was just complaining about a headache. The next day, she goes to her doctor's appointment. They notice that her blood pressure is really, really high. They tell her that they're going to admit her into the hospital. It looks like she's showing signs of developing preeclampsia. Because preeclampsia is developing so fast, they tell us that we're going to have an emergency C-section. On October 20th, Charlotte is welcome into the world, and we're just both excited.
We're all in the text thread like congratulations and sending all of the emojis and the memes, and then it gets serious and it's our sister is not doing well, our friend is not doing well, Shanice is not doing well.
She ended up having a brain aneurysm. They wrote her brain dead officially 4 days after Charlotte is born.
She was so young, and she didn't get that opportunity to be a mother.
My mom dealt with preeclampsia with birthing me. It's like, why are we still dealing with preeclampsia like right now? Why did Shanice have to be a victim of preeclampsia, knowing that 33 years ago, this was something that my mom dealt with and made it through? You know, it's kind of hard to think about Charlotte not having the same privilege that I had of being raised by both her biological parents. But I know she's still surrounded by so much love.
With Shanice's passing, the desire to want to learn and support Black mothers like never before has increased. I feel like it is my duty to ensure that I tell them the things that I learned, like having a second ear, advocating for yourself.
Being a physician herself, being intelligent, maybe there were times where she needed to share with me some information, but she didn't want me to be concerned or me to worry. You know, if I could speak to women, I would want them to consider themselves. Take how you're feeling so seriously.
And then our last story is Dr. Shalon Irving's story.
I hope you never have to read this letter. I cannot imagine you having to go through this yet again. And if you are, I am so truly sorry, Mommy. I hope you know how much I love you and how much you mean to me. I am sorry that I have left you. On the particular day that I am writing this, I have no idea how that may have occurred, but know that I would never choose to leave you. You will forever be my mommy, and I your baby girl. Shalon was my only daughter. She was loving, she was kind, she was generous. She was just always a curious child and loved to learn. She graduated from high school after skipping 2 grades. She went on to get her bachelor's at Hampton University. From there, she got a master's of science and then was accepted into a PhD program at Purdue University. She graduated with a dual PhD in both sociology and in gerontology, and she was the first student to do that at Purdue University. Both degrees were summa cum laude, and all by the age of 25. She went on to public health because she had watched her brother, who was battling MS, so she decided she'd go and get a Master's of Public Health from Johns Hopkins, and then went on to become a well-respected epidemiologist at the Center for Disease Control. Unfortunately, her brother passed away, but she still devoted the work that she did at the CDC to her brother. Shalon was a very adventurous spirit, and we had traveled to over 20 countries in the last 5 years. She just loved life. When Shalon found out that she was pregnant, she was just overjoyed. She had wanted to be a mother for so long. She went to every single OB appointment. She did everything her obstetrician required of her. She had had fibroids removed probably a year before the pregnancy. And then she found out at the time that she had factor V Leiden. So she also had to take 2 painful shots every day to keep from clotting while she was carrying her baby. Well, based on her history, her medical team thought it was best that she have a planned C-section. She was prepared, she was ready, and she couldn't wait to meet the tiny human that she'd been sharing space with for 37 weeks. Shalon had tears in her eyes. She was so excited to see her daughter, and Shalon just held her. Within 4 or 5 days after getting home, she developed a lump on her side. She started having other symptoms as well, headaches. She wasn't voiding as she should have been. Her legs started to swell. She started to gain weight. She had headaches. And every time we'd go in to see a doctor, she was just dismissed with, "You just had a baby, give it time, it'll get better." And she says, "Mom, I don't feel right, there's something wrong." And I was just so concerned, but I didn't know what to do. During the last week of her life, Shalon went to the doctor 3 times for the same symptoms. On that last visit, she presented with blood pressure of 174 over 120. "Well, let me give you some blood pressure medicine and you go home and come back in a couple of days if it hasn't gotten better. But don't worry, it should be fine. Just give it a little more time." Well, after we left the doctor's office, we went and picked up her prescription and we came home. And so we were sitting there talking a little bit more, and all of a sudden, she started to have this gargled sound that came out of her mouth, and her arm shot up, and she passed out. And I called 911. Probably 5 or 6 minutes later, the ambulance was there. When I got to the hospital, the emergency doctor told me that she was in pretty bad shape. I found out a couple of days later that she was brain dead because of the lack of oxygen. My cousin brought in a medical directive that I didn't even know Shalon had. And it said, "Mommy, I will fight hard, but if there is no hope, please let me go." And the next night, I happened to notice just one tear. It seemed like that came out of one eye. And I knew then what I had to do. We had her taken off life support. At 9:14, she was gone. I lost my vibrant, beautiful, intelligent best friend and daughter because she wasn't heard. I knew Shalon was a high-risk pregnancy because of her age, but I never for a moment thought that she was at risk of dying because she was a Black woman.
All right, so these 3 stories are just a few stories of what happens across all races and ethnicities to moms, especially those who are postpartum. I get up every day and I do my job because I do not want there to be another Shalon, another Kira, another Shanice. I look at myself and I see them. I look at my friends and I see them. I look at my mother and I see them in her. If she had not advocated to give birth to me, I would not be here in front of you today. So that's my why on why I wake up and do this every day. So I just want to thank you guys for inviting me to participate and allowing me to present on maternal child health. Thank you.
Well, the story certainly seems to be as disturbing as we suspected. At this time, we will take questions from anyone who might like to ask Lauren. We've got a couple of microphones with people that they will deliver around each other. So, looks like Nancy back there.
Lauren, what's being done to increase the number of doulas, or how do you do that?
So currently, Indiana Medicaid is looking at reimbursing doulas at a higher rate. So right now, doulas are lumped in with community health workers. So they get paid, let's say, $9 for every 4 hours of work, right? So they can't live off of that. So Indiana Medicaid is currently setting up a higher reimbursement level for them to increase access and allow doulas to live comfortably, to be able to serve individuals, especially those high-risk individuals who are in Medicaid.
Where do you recruit doulas? I mean,
Yeah, so doulas have been around for generations. They are becoming popular now due to the increased knowledge on this maternal child health issue. So for our program, the majority of doulas that have entered our program weren't doulas prior to. We put them through training through Donor International for them to become certified, and we pay for that cost at IMHC. So getting them trained, but there can be a barrier. Trainings can range from about $700 to about $1,500, depending upon where you get trained through.
Other questions?
Lauren, one of the things that you said early on was 1/3 of women in the state live in an OB desert. That's astonishing to me. Is there anything that can be done to address that inequity and lack of access?
Right now, I'm gonna say no, just because of the restraints that have been put on providers. So if you live in a rural county that has 2 OB providers or 1 OB provider, but they decide to move and there's nobody to replace them, you just become an OB desert. I do not know what the state is doing regarding moving individuals here, especially with the passing of the abortion ban here. Puts a restriction on providers wanting to come to the state of Indiana.
I was just going to say, with Roe v. Wade and then what happened here in Indiana, I'm hearing that a lot of OB-GYNs are leaving the state. So what do you think that's going to do to this maternal child health?
It's going to make it worse. I think about women who might not be able to access an abortion, who might be killed for that. I've heard stories about women who were killed for being pregnant. Their partners or the person that they got pregnant by did not want them to have a baby. You think about the influx of babies that are going to be going into kindergarten 5 years from now in an already strained educational system. So I personally don't think that is going to work out.
Other questions?
Yep, so that passed in 2022, yep.
We have a lady over here.
Okay, great. First of all, I want to say thank you so much for that presentation. That was wonderful. And secondly, I'm curious why, I love the IMHC doula programs. I think what you guys are doing is amazing. Curious why you're not in Marion County.
Yeah, so we overtook the doula program from another nonprofit that had already established a program up in those counties. So we would like to eventually move down here, but with everything, it costs money, right? So applying for grants and getting funding to establish that, because the program, I don't know if I mentioned this, program is completely free for women. They pay nothing. They get diapers, they get diaper bags, they get playpens for their babies. So we fund everything completely.
I have 2 questions. First of all, you explained to us a bit about what the root causes are, why these mortality rates are high. Why is it that Indiana is so much worse at this than others?
I would say a big reason why, I think we're one of the fewest states that put money towards public health. And so if you're not putting money towards public health, then you have these conditions and we get these low numbers.
And if no one else, I have one last question. What can we do as a congregation to help in this vitally important issue? And particularly to help your organization? Are there things that we can do?
Yeah, so I didn't touch on this, but we also do virtual baby showers. So we've been able to partner with MCEs such as CareSource, MHS, and Anthem to do virtual baby showers for pregnant women across the state of Indiana. Virtual baby showers, we like to say, is fun and education. So they play the Price is Right. They get to win prizes such as like a stroller and a car seat, so big prizes to me. And then we have educational topics such as WIC, breastfeeding, lead testing, advocacy, doulas, and whatnot. And so our past Anthem baby shower that we had was a Spanish-speaking only baby shower. So all of our presenters spoke Spanish. Price is Right was played in Spanish, so which was great for that community. And I'm looking to hopefully do one in Haitian Creole as well too, to decrease those barriers. And then we also host an ECHO program. It's called the Black Maternal Health ECHO. It's in partnership with the IEPUI ECHO Center, and it's sponsored by CareSource. And that's a 12-month-long program for birthing professionals. So if you work with any pregnant women at all, you're welcome to attend, even if you want to learn more information about maternal child health, especially as it relates to Black women. So those are done on the first and the third Wednesdays of each month from 11:30 to 1. It's just a time for providers to come and to learn about different topics relative to preeclampsia, stillbirths, access to care, racism in medicine. And then the next half of that hour-and-a-half session is de-identified case presentations. So attendees are able to present on a client or a patient who's having some difficulty. So for instance, we had a doula present. She has a client living with HIV. Client's family was not educated on the advancements of HIV, so they did not want her to use any kitchen utensils. They didn't even want her to go to the bathroom in their house. So therefore, she had to move out of the house. So our doula presented on that client in terms of how can she support that woman that's going through that, living with HIV, and then how can she educate her family on the advancements that have been made in HIV so they aren't stigmatized and then therefore treat her wrong. So areas and what can be done here at Northminster, I would say just supporting the programs that organizations do with MCH. I can definitely send flyers or anything relative to events that we're hosting to you guys. If you guys would like to participate, you're more than welcome to. We recently just did one with all the managed care entities, so Anthem, UHC, CareSource, MHS, and MDYs. We had a webinar with all of their DEI experts on what they're doing relative to MCH here in the state of Indiana, especially as it pertains to Black women and babies. So I'm always down to send flyers, anything you guys' way if you guys would like to participate.
Very good. Oh, we got more questions. Hello.
This is a soft side question, but do you have any data or statistics on students in medical school, what they're doing in regards to not listening to a woman of color? Because I know that 30 years later, it's still happening. It happened with me, with you.
Mm-hmm.
They didn't listen to me, and unfortunately, everybody, the doctor couldn't get there. There was a bad storm that night. He lived on the other side of the reservoir. A tree had entered the roadway, so he couldn't get there. The nurses were arguing. It was just a bad situation, and the cord had wrapped around Lauren's neck. So it was an emergency C-section, and he just wouldn't listen to me for hours and hours. So that's why I was asking if there's any data or statistics, whether or not they teach this subject in college. Or med school, I should say.
Yeah, I am not sure on the level of specificity in terms of how they go about teaching maternal child health. I know that there was a report done a few years back, maybe within the last 7 years, that medical students thought that Black individuals had tougher skin than white people, which is not not true at all. And so we are working at IMHC and at other organizations to help address that. So working with individuals who teach in medical schools. I know I created a partnership with IU South Bend's nursing school for my doula director to go in and to talk to the nursing students about doulas, because a lot of them didn't know what a doula was. And about, I think 90% of the graduating seniors that are in nursing go out and teach in the St. Joe community. So if they see a face that's familiar, they're more likely to be approachable, you know, to be friendly, and to let doulas work alongside them. So just getting in and creating those relationships with schools.
We have another question over here.
Hi, Lauren. My name is Charles Scott, and thank you for the information. Great sharing. This is personal and near and dear to my heart. I'm actually from Tennessee, and I really want to talk a little bit, and I'm not sure how this would work in Indiana.
Mm-hmm.
I grew up in the great state of Tennessee. My mother was a midwife. She assisted ladies in rearing, I guarantee it was well over 50 or 60 women. Because during her era, African American women could not go to a hospital. So she was a midwife. And so obviously the data speaks for itself.
Mm-hmm.
And when you look at the actual data that was presented, the elephant in the room is that African American women suffer a lot from this.
Mm-hmm.
We know that. So the question becomes, how do we look at initiatives that will help the population that's most affected, based upon the data, not based upon what we think, but based on the data? How do we address that? And obviously, you know, midwives, that's risky. Of course, now we can't do that because, you know, people are lawsuit prone. But I know if it wasn't for the midwife, I wouldn't be here today. I know that, without a doubt. Because back during those days, it just wasn't, and like you said, on the actual data, right? Then African American ladies, and yes, this is not, I'm not turning this into a racial discussion. It's not about race. This is about a life. So please don't misunderstand me when I say this. It's not about race. The data shows what's happening, right? How do you address that? That's the piece, I guess. I know I'm rambling on, but it's somewhat emotional because I know what my mother did.
Thank you very much for sharing, by the way.
Yeah, definitely. Thank you for sharing your story. We struggle with this every day. There's an elephant in the room, right? Black women and black babies suffer at a higher rate. So you just can't throw something at the wall and hope it sticks. You need to find initiatives that specifically work for black women. So like those zip codes that I showed you, having programs in those zip codes to address. You know that black babies die in 46201 a lot, right? So putting programs in those specific areas to address that. Oftentimes, people just want to do a one-size-fits-all, and that doesn't work. That hasn't worked. It will not work. I didn't mention this, but at the rate that we are decreasing black infant mortality, it'll take 52 years for it to catch up to white infant mortality, and that's if white infant mortality does not decrease. I know that I will be close to death at that point. So this is not an overnight fix. It took us 400 years to get here. It's going to take us generations to get out of. And so if you look at different models that address based upon higher need races and ethnicities, focusing on that and putting those into those communities, I think would help address. So doulas, midwives that I talked about, like you mentioned, black midwives used to be heavily popular during the slave times, but they were forced out of the profession. So bringing midwives back into the fold and allowing them to work alongside OBs, because we're not saying, oh, no, hospitals are horrible, you shouldn't have an OB. Definitely not saying that. But allowing and diversifying different care models is what needs to be done.
Lauren, I think you're very popular. I believe we've got 2 more questions over here.
We've got a question from the internet, Facebook, and the question goes this way. What can be done legislatively or otherwise to practicing OBs who are ignoring African American symptoms?
What was that last part? Who are ignoring African American women symptoms? I know that Representative Vanessa Summers has tried to pass like implicit bias, hasn't got picked up. As I mentioned, caveat, it's difficult to get legislation, especially maternal child health legislation, passed here in the state, just because we are a heavily conservative state, and some representatives and other individuals don't feel like this is a big enough concern. But Representative Vanessa Summers has tried to get implicit bias training passed or some type of training for providers on this. So that's where you guys kind of come in and contacting your legislators and letting them know that you're aware of this issue. I can send potential bills. Ledge season is happening in January. I think it goes January to February. I think it's a short session. So I can send you guys bills on potential legislation that can be sent out to the masses. And if you can call your legislator and let them know, hey, I would like for you to pass this bill. This is what I would like to be done.
Okay.
I had one question. First, I'm sure everyone can give to your organization probably, but how much would it cost you to add a doula program here in Marion County?
It depends upon the number of staff. Couple $100,000 upwards.
As well.
Building, putting them through training, hiring the staff, paying for mileage reimbursement, paying for like diapers and stuff. It's free. Diapers are free to the clients, but we have to, as an organization, incur that cost for them to be free. So, yep, upwards.
We there? Well, I would like to.
I'm sorry.
Oh, we got one
I would
more.
be
Okay,
remiss. Yeah,
No.
I would be remiss if I didn't.
All right.
First of all,
Please.
yeah, thank you. First of all, my name is Stephanie. I was here on Sunday with the Little Timmy Project, and I just would like to say this congregation has supported our organization. We are focused on infant maternal mortality, and we have a birthing essentials pantry in 46201. That you all have supported as a congregation. Also, we have a BIPOC Doula Scholarship Fund here in Marion County, and we've been able to provide 30 scholarships to doulas of color, also supported by this congregation. So I just wanted to say thank you for doing that, whether you knew you did that or not. We really appreciate it, and Lauren, we came to this specifically to meet you and maybe talk about ways that we can bring the services that you all provide into Marion County. So just wanted to say thank you and share that little piece. Collaboration over competition, you know what I mean?
Thank you.
Okay. I'd like to thank you from the bottom of my heart for your wonderful,
Thank you.
very poignant presentation tonight. So let's all give her a Just a couple of comments before we close this evening. Our next Northminster Presents is on November 8th, Wednesday at 6 o'clock, right here in this church. And we have kind of a subset in our program that we call Fireside Chats. And it's exactly that. We are having a fireside chat with our beloved Reverend Carol McDonald, who is going to reflect upon her life and ministry, with the facilitator being Jennifer Diswaner. I'd encourage you all come. I think this night will tug your heartstrings, and to show respect to this wonderful, wonderful woman. So thank you all for coming this evening. Thank you those that are on the internet, And we appreciate everything you do, and God bless.